Hi there, welcome. My name is Radib Akhtar. I am a family medicine attending. Today we'll be talking about ECG interpretation. We'll be going over practical and quick interpretation of an ECG here. So the things that I won't be covering, I will not be talking about conduction physiology, how to record an ECG, and pathophysiology. This talk is mainly geared towards our residents who are starting, but anybody who wants to know how to do a rapid interpretation, this is a good one to review. All right, why don't we begin? So here we have an ECG, and some basics to know are what the boxes mean here. So one of these large boxes really measure to be 0.2 seconds. And the small box, for example, like right there, that's equal to 0.04 seconds. So these are some measurements that you will have to memorize because when we calculate intervals and those sorts of things, we will have to know how much a box represents, a big box and a small box. Okay? And then also just to review, when we go over the complex here, we'll look at the different parts of the wave. So for this part right here, this is our P wave, this part is our QRS complex, and then this is our T wave right here. And so this would be, we'll review this later, but this will be a sort of a normal PQRS T flow here. Okay, so in terms of interpreting this EKG, why don't we go ahead and look at it? And then the key principles here to interpreting EKG is to develop a system. As long as you cover all the elements of the system, you will have covered probably over 90% of what you need to know for this ECG, or most ECGs that you encounter. Some of the more zebra things that come up, like Brugada syndrome and things like that are very specific, are going to be, through clinical experience, you'll look for those things as indicated. So with this ECG, let's start with our interpretation systematically. The first step is to look for the rate. And there are different ways you can look for the rate here. Usually what I do would be to count between the one R and the next R. When you go from large box to large box, it is the beats per minute as indicated. So here would be 300, this would be 150, this would be 100, 75, 60, 50. When we do these, you do have to memorize the numbers here. So 300, 150, 100, 75, 50. So this method you do have to memorize. And with also this method, you do have to make sure you have a regular rhythm. If you have an irregular rhythm, this method would not be as helpful. According to this, we have a rate of 60 beats per minute. And when we look at our rhythm, it looks generally regular, but we'll get to rhythm soon. The other methods to calculate the rate would be to count the number of R's you have and you multiply it by 6. So number of R's times 6. So if we do this, we can count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 times 6 equals 60 beats per minute. In this method, you do have to make sure you have a 10-second lead, 10-second EKG. If you are on telemetry and you're looking at a lead strip, this method will not apply to that because you don't have a 10-second strip unless you get a 10-second strip. The last method to determine rate is you look at the number of large boxes between an R and another R, subsequent R. Okay, and then let's say for here you have 1, 2, 3, 4, 5 large boxes. You take 300 and you divide it by 5, and that gives you 60 beats per minute. Okay, so with all the methods that we used here, we get the same answer. You don't have to use more than one method, but just use an appropriate method and use it. And so for here, we have 60 beats per minute. Okay, the next step in our systematic interpretation is to determine the rhythm. When you determine the rhythm, the basic questions to ask are, do you see a P wave before every QRS complex, and do you see a QRS complex following every P wave? So here, if we look at the strip lead 2 that goes across, we identify every P wave here. Okay, and then we see that they're pretty regular here, and then we see a QRS following every P wave that we identified. I don't see any extra P's or extra QRS's. So therefore, I will say that this rhythm is sinus. Great. Okay, so the next thing that we review in our interpretation is axis. So with axis, the way to interpret is to look at two leads. The specific ones would be lead 1 and lead AVF. The general idea, that's the quickest way to do it, is if both of them are, if the QRSs are upgoing, then you have a normal axis. So by that, what I mean by that is if the QRS is positive, meaning upgoing from the isoelectric point, so that line would be sort of the isoelectric point, then both the AVF ones and then the lead 1 ones are up, then we have a normal axis. So here we can say that our axis is normal. Great. Just for knowledge's sake, if our lead 1 is ever down, this implies a right axis deviation. If both lead 1 and AVF are down, that will cause extreme right axis deviation. If this is up and AVF is down, then that's left axis deviation. Okay, great. So our axis here is normal. The next step in terms of interpreting our EKG here is to go over the intervals. So this is an often forgotten part of the interpretation, but it is super vital, and it covers various elements that's very important. So I'm going to go down to the main lead here, the main strip here, and then we're going to look at our intervals. So let's say we're looking at this wave here. The first interval we want to identify is our PR. Okay, so to identify this interval, we want to look at the beginning of the P wave, which is right there, and the start of the QRS complex, which is right there. Remember how much a small box is in terms of the measurements. So we could say small box is 0.04 seconds, because we'll need to do a little math here. So here we'll say it starts there. We have 1, 2, 3 small boxes. So our PR interval would be, for here, 3 times 0.04 is 0.12 seconds. Normal PR interval should be below 0.2 seconds. So for normal PR, how much is 0.2 seconds? And that's one large box. So if you notice that your PR is getting close to a large box or larger than a large box, or longer than a large box, then you're dealing with a prolonged PR interval. Here our PR is fine, it's 0.12. All right, so let's go back to the complex. So here I'll just write here PR is 0.12 seconds, just to keep that there. All right, let's do our next interval, and our next interval is the QRS complex. Here we start here and we end right there. So it's one small box, and we could even, if we really want to look at another one just to double check, maybe 1.5. That looks like it's 1. So let's say it's one small box, so our QRS is 0.04 seconds. Normal QRS interval is going to be less than 0.12 seconds. All right, so a normal QRS is 0.12, less than 0.12, so that would mean it would be 3 small boxes about that wide. So if you have a wide QRS that's 0.12 or greater, then you have a wide QRS complex. So here our QRS on this strip, on this ECG, is going to be 0.04, which is normal. Okay, for this part of the interpretation, you do want to mention the exact measurements here. And if you're just doing a rough interpretation, you want to just make sure they're normal. All right, so let's do our QT measurement. So for here, we will start at the QRS complex and we'll measure to the end of the T wave right there. So let's count the boxes here. We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we have 10 small boxes. So 10 times 0.04 is going to be 0.4 seconds. Okay. Normal QT interval is a bit different because it's based on sex. So for men, a normal QT interval should be less than 0.44 seconds. For females, it should be less than 0.46 seconds. When I do a rough interpretation, I check to see if the QT is bigger than 2 large boxes, which would be 0.4 seconds, and then if it is, then I actually calculate and measure it. So here in our ECG here, our QT is 0.4 seconds. Okay? So remember, intervals are super important. You'll be able to identify heart blocks. You'll be able to identify prolonged QT, left bundles, right bundles, those sorts of things. So I'm just going to put them here. So our PR is 0.12 seconds. QRS complex is normal, 0.04 seconds. QT interval is also normal at 0.4 seconds there. All right, so the next and last thing is going to be looking for signs of ischemia, infarction. Okay, and to do that, we have to know our different signs of ischemia and infarction. So the first one is going to be T waves. So let's look at the T waves, and the way I normally do this is I look at the entire EKG and I put my eyes on every T wave from every lead, and I want to see that they're all upgoing where they're supposed to be upgoing. So I'm looking at all the T waves here, and they all look normal and upgoing the way they're supposed to. The T wave can be is usually normally downgoing in the AVR and can be normally downgoing in the the V1 lead. So that looks all normal to me. So I don't see any T wave inversions where they're supposed to happen, where they are not supposed to happen. Okay. So I'm going to say T waves normal, and we look next for ST segments, and we want to see if there's any ST segment elevations or depressions. So same thing I do with my eyes. I look at every lead, looking for any ST changes. So just to clarify where the ST is going to be here to the T wave, which is going to be this part. So if you get an elevation which may appear like this, then that would be a significant elevation. Significant ST segment elevation is going to be more than 1 millimeter. Okay, and that is one small box. So if you have an elevation over this isoelectric point that's more than one small box, then that's going to be a significant ST elevation. Okay, and lastly, you want to look for signs of ischemia infarction in contiguous leads, which I will explain in a moment. So let's see here, when we look for the ST segments, this looks normal on all the leads. Okay. And that might be a little bit of an elevation here, but likely non-specific. So okay, so there you go. So I'm going to say that all the ST segments are normal. And lastly are looking for Q waves. So Q waves are a little bit tricky in identifying. Q waves are also a sign of ischemia infarction. So the way that a Q wave looks is it's going to be your first downgoing beat in your QRS complex. So when you have the P here, the Q wave is going to be the first if you get a down spike, and then you get the R, and then the S, and then you go into the T. So this down spike is going to be your Q wave. And a significant Q wave is going to be a one box large either way. So it's going to be a greater than one small box wide and one small box deep. Okay, so that's for significant Q wave. And again, you glance your eyes at every lead here. So let's go ahead and look at everyone. That looks fine. No Q waves, no Q waves. That looks fine. No Q waves, nope. Nope. And you could see like a slight one here, a little notch there and there, but those aren't significant in terms of the one box wide and one box deep. Okay, so I don't see any Q waves, I don't see any ST segment elevations that are significant, and I don't see any T wave abnormalities. So I'm going to say none here. So this EKG looks pretty normal to me. Just to get back to the signs of ischemia infarction, lastly, are going to be identifying when you see abnormalities if they're in contiguous leads. So that has to do with the anatomical placement of the leads. So lateral leads would be 1 AVL. Okay, and so we'll say lateral. Inferior leads are 2, 3 AVF. Okay, so that would be inferior. And then anterior, these are typically septal, and then that's also anterior, and then this will also be your lateral leads, the V5, V6 as well. Okay, so generally the anatomical placement is important, and if you let's say you get T wave inversions here and here and here, then you get worried about prior ischemia in this region. So then you worry about ischemia in the inferior part of the heart, and so forth, and you can apply it to the other anatomical locations. Okay, so that was a rapid interpretation of this EKG. This EKG was a bit boring because it was totally normal. We will be throwing you some abnormal ones and interpreting abnormal rhythms and rates and other pathologies, which will be interesting. But if you get this system down here, then you will catch them all. Okay. A good resource that I use to look at EKGs in practice is a website called Wave Maven, and that's a Harvard-based website. The link, I believe, is down here. But if you type in Wave Maven in a search engine, you'll be able to find the EKG and look at practice ones, and there's also practice questions. A lot of EKG review is board review as well, so I definitely recommend getting excellent practice at this and doing full interpretations when you're able to. Many of your attendings may ask for them, so be ready to go through all of those steps. All right, take care.